Wow, good morning. I'm indeed honored and humbled to receive this award today, and thank you, Dr. Toomey, for that wonderful intro. I thought you were going to tell another story, so I'm glad you did it. So, as usual, when you get an award, you always, at least I do, I feel always guilty because there are so many people that are responsible for me being where I am today. It's the people who have been my mentors. It's the wonderful people that I get to represent in the Division of HIV/AIDS Prevention, who has, I believe, some of the most talented and committed staff at CDC. And it's the many public health folks, the community folks, and others who I get to meet when I'm out in the field that constantly inspire me to do the work that I do. And you'll hear, when I finish today, you'll probably figure out how old I am, and that's not my intent, but in order to tell the story today, I'm gonna have to give you some points in time that will tell you a little bit about me, my age. But 38 years have really, let me just make sure I can control this. Good. So 38 years have passed since the first case of AIDS, since the first cases of what was eventually known as AIDS was reported to CDC. This means that some of you in this room have never known a time without HIV. It also means that some of you don't know or remember what a diagnosis of HIV or AIDS meant back then. There was a lot of fear and stigma, a lot of ignorance. There were too many funerals. Many partners, family, and friends were left behind. If you weren't there, it's really hard to imagine the fear that AIDS caused in the community. I began my public health career in 1983, just before the virus that causes AIDS, or HIV, was discovered, and the first diagnostic test became available. Back then, there was a lot of hope when there wasn't really a lot of hope when a person was diagnosed. And I had the fortune to be able to work in an early care HIV clinic. And at that time, when people came in, there wasn't much I could tell them. But when treatment became available in the late 1980s, and I think some of you who were around remember Zidovudine or AZT, it really people felt optimistic. But the treatment at that time really was very, very challenging. It required taking many pills, often with many side effects. But the promise of more effective and safer treatment gave us the hope that one day a diagnosis of HIV would no longer be seen as a death sentence. The hope was realized in 1997 when highly active antiretroviral therapy, or HAART, became the new treatment standards. Over the next few years, we saw almost a 50% decline in HIV death rates. Today, HIV treatment is easier than ever. It's very simple. You can now treat HIV with a single pill every day, and with very few or no side effects. People with HIV who are on treatment and virally suppressed can remain healthy and live almost normal life expectancy. And people with HIV who keep an undetectable viral load have effectively no risk of transmitting HIV to their sexual partners. This message is consistent with the U equals U, or undetectable equal untransmittable community campaign that many of you know, and that is so important to address stigma and get rid of some of the misconceptions about HIV. HIV treatment is now HIV prevention. If someone had told me 25 years ago that HIV treatment was HIV prevention, I wouldn't have believed them. And I think many of you in this room wouldn't have, and it has taken a while for some of the folks in the medical community to even believe that this is true. But the data are irrefutable. HIV treatment is HIV prevention. U is equal U. So we need to just get that out of the way and do what we need to do. So I hope that today, I can really inspire each of you to think bigger about what we can do together to end HIV. We're now at a place in time when we know what to do to end HIV. We have access to the most powerful HIV prevention and treatment tools in history. We know where HIV is spreading most rapidly. The time is now. In some ways, we've made enormous progress. Since the height of the epidemic, we have reduced the number of new HIV cases by more than 2/3. But even as we recognize our progress, we must be honest about where we are falling short. Why is it not moving? Do I have to point it somewhere? Okay, just there, okay. So one of the realities we need to face is that not everyone is benefiting equally from these successes. There continues to be startling disparities. Gay and bisexual men, African Americans, Latinos, and people aged 25 to 34 bear the greatest burden of new HIV infections in the United States. And nowhere are those disparities more startling than right here at home in the South. Dr. Toomey mentioned to you that this is my home. It's truly home for me. I went to Morehouse in the 70s. And so I'm a Morehouse man, and I grew up in rural South Carolina. On my name tag, I have the name Bishopville, and somebody says, Bishopville, where is that? Well, I can tell you where it is. It's in rural South Carolina, in the poorest county in South Carolina called Lee County. Lee County. So get that. And it's 70% Black and extremely poor. That's where I grew up. That's what I know. But I've been in Atlanta since '83 and have lived and it basically consider Atlanta my home. So with the proposed ending the HIV epidemic, we have an historic opportunity to end HIV in the United States. The initiative will leverage crucial scientific advances in HIV prevention, diagnosis, and treatment, and care, and will engage many agencies across HHS and other parts of the US government to implement a comprehensive and coordinated response. As mentioned earlier, we want to focus on the hardest hit areas first so that we can achieve the greatest impact. And the goals are stated here, and you've heard them earlier, and that is to reduce new HIV infections by 75% at the end of year 5. After the first 5 years of the initiative, and probably sooner, resources and activities are going to be expanded to the next highest burden areas, and then over time to all areas so that we can reach our goal of a 90% reduction over 10 years. And what this 90% reduction translates to is less than 3,000 new infections per year. So it's not eradication, it's elimination. And the goal is to, if you can get HIV reduced to a certain level, you can really stop new transmissions from occurring. So the initiative is really going to be focused on bringing to scale interventions that we know work, but it's also going to support innovation. And I'll talk a little bit more about that later. This is a direct and bold approach to provide the hardest hit communities, including Fulton, Gwinnett, Cobb, and other counties in the areas with the additional resources required to address their own local HIV epidemic. And the 4 pillars of the initiatives are really listed here, and it really is the diagnose, treat, prevent, and respond. So if funded, the EHE initiative will provide additional resources needed to eliminate new HIV infection by rapidly deploying cutting-edge and innovative HIV prevention and treatment strategies in specific communities where the need is greatest. Now, I want to talk about what it will take for us to really make a difference in addressing HIV in America. Our toughest challenges right now are not biomedical or technological. We have the tools. The challenge we have is getting those tools to where they need to be. And the challenges are mostly social, structural, and economic. And I don't know if many of you recall the slide that was shown by a colleague from Fulton County, and when you look at where the low viral suppression rates were, they were in folks who were basically, they were African American, they were persons who inject drugs, they were transgender persons, they were marginalized populations. And many of those marginalized populations are really burdened by the social and structural and economic barriers that we see commonly and especially in the South. So ending the HIV epidemic will require addressing some of these barriers, such as stigma and discrimination, unstable housing and homelessness, lack of transportation, which was mentioned earlier, inadequate or no health insurance, a big problem in our southern states, lack of culturally competent care. The young lady, and I apologize for not remembering your name, that is the receptionist that greets people when they come in the door, is really critical that that person be a warm and loving person, and I really applaud you for the work that you do every day and being recognized by the community, because you treat people with dignity and humility when they walk into a clinic or walk into a space, they're gonna wanna come back. But if you don't, they're not coming back, and even if they really need your help. We also need to address the lack of mental health services, some of the issues related to low socioeconomic status and poverty. But most importantly, we must address the homophobia, transphobia, and racism that exist in communities and various healthcare settings to eliminate the subtle sort of microaggressions that people experience when they walk into a clinic or they come and talk to you about specific services. But we've got to start at home. We've got to deal with this at the federal level. We've got to deal with it in the public health settings, and we've got to deal with it in the community. And those are going to be critical if we're going to move forward. So as I mentioned earlier, we've made a lot of progress in reducing new HIV infections or incidents since the height of the epidemic, but progress is leveling off. Like you saw with Georgia, our national data show that HIV incidences level off since 2013 to about 39,000 new cases each year. Although we're seeing decreases in certain populations, such as white men who have sex with men, heterosexual or cisgender women and cisgender men, and persons who inject drugs, this progress has really been uneven. These data tells us that we are not adequately reaching those who could most benefit from our prevention and treatment advances. Men who have sex with men, or MSM, are the group most affected by HIV in the United States, accounting for about 70% of incident HIV cases each year. Although the number of new HIV infection among Black MSMs has been stable over the last few years, this group continues to have the highest number or highest burden of incident HIV cases. And recent trends shows us that Latino MSM has experienced a 30% increase in HIV incidence between 2010 and 2016, and the data looks similar for 2017 and 2018. Regionally, Regionally, the South accounts for half of all annual HIV infection, and nearly 1/3 of those infections were among Black, gay, and bisexual men. So I've been at this work for about 35 years, and the thought of what legacy I will leave looms large in my mind. I can think of no better legacy than knowing that my life work could contribute to a future where no persons will have to face a diagnosis of HIV. Many cities across the world have committed to ending HIV in their jurisdiction and have signed on as fast-track city. Atlanta is a fast-track city. And what that means is that the city leadership has made a commitment to achieve the UNAIDS now 95, 95, 95 targets by 2030. And what does that mean? That means that they've made a commitment to ensure that 95% of the people living with HIV know their HIV status. That 95% of the people who know they're HIV, who are HIV positive, are on treatment, and that 95% of those that are on treatment will have a suppressed viral load. And that translates into an overall viral suppression rate of about 90%. So these numbers are really important. They're ambitious, but I think they are needed if we're going to eliminate HIV as a problem in the US. To reach this goal, we're gonna all have to work together. We are one community and we're all in this together. Those of us who work in HIV cannot do it alone. We have to bring in other partners. We need to think about who else needs to be at the table and can help us with this. It means bringing in communities that we have not thought about before. It means getting businesses involved, getting the church involved. I'm looking at my colleague. Getting the church involved, getting non-traditional partners like the Walmarts and the others, the businesses, and so getting them involved and ensuring that and really finding space for them to respond and help us in this initiative. One of the things that my director talked about is disruptive innovation. And I want to sort of say a little bit about what we think he means by that and what he's tried to explain to us. And that is, one of the things he likes to say is we cannot keep doing the same thing the same way over and over and over and expecting a different outcome. We've got to do things different. And we believe that the community has the answer. We need to be engaging the community in identifying what works for them and implementing some of these programs and allow some disruptive innovation, not doing all of the same things. But when we implement these disruptively innovative projects, we need to make sure those projects are being thoroughly evaluated so that we can document impact and then really learn from them and quickly spread those lessons learned to others. So, yes, good. So we are looking at a once-in-a-generation opportunity here to end HIV in America. What a gift to leave the next generation. Change is within our grasp, and we must rise to the challenge. Our ability to eliminate HIV will depend on our collective ability to think in new ways, focus on what works, and confront the ongoing social, economic, and structural barriers to prevention and treatment. We must prepare for tomorrow's advances by capitalizing on the tools that we have here today. When Magic Johnson announced that he was living with HIV in 1991, there wasn't much hope for people who were living with the virus. Even so, Magic Johnson remained hopeful, and you can see the quote that he had made there. We've come a long way since then. When I see the progress we've made and all the success now within our reach, I'm very excited and I'm very optimistic. Now is the time to act. Now is the time to end HIV. Thank you.